session of this teaching. And today our topic is opioids case-based learning. So during this session, there will be discussions regarding converting from step 2 to 3 and phenyl to morphine, vice versa, buprenorphine to morphine and vice versa. Again, immediate release morphine to sustained release or to subcutaneous morphine. Also, there will be case-based learning, various issues related to opioid use, side effects, and the suspected inappropriate use. So today we have an eminent faculty to deal with this session. She's Dr. Meenakshi. She's an associate professor in Adyar Cancer Institute. She's a associate professor and she has an long experience in anesthesia as well as palliative care. She did her MBBS from Kilpauk Medical College, Chennai, and she did anesthesia diploma and MD from CMC Vellore. She also did National Fellowship in Palliative Medicine in 2018. She has 5 publications and 3 paper presentations, and her area of research is methadone in cancer pain and pediatric palliative care. This will be a different session. This will be a very interactive session. So we request all of you to be very attentive to this session and give your answers through the chat box. And this will be definitely a very useful session. So everyone be attentive. And we welcome you once again, ma'am, to this session. And over to you, ma'am.
Thank you. Thank you so much for that kind introduction. Good evening, everyone. Are we going to wait for somebody or can we get started?
I think we can get started, ma'am.
Yes. In the interest of time, can you share the screen, Rajlakshmi, or you want me to share it?
I can share it, ma'am. Give me a second.
Or probably, is it better that I share it because then I would know what to...
You can share it, ma'am. No worries.
Yes, I think, have you made me co-host or whatever?
Yes, you are co-host, ma'am.
Okay, just 2 seconds, and I need to share screen. Forgive me, I am not very where have I lost my screen? Okay, I just have to share screen now. Let's see, and I select this, right?
Yes, ma'am.
Okay, and we go to the presentation mode. Are you all seeing my screen?
Good to go, ma'am.
Yes, ma'am.
Good to go? Yeah. So once again, thank you, Pallium India, for this wonderful opportunity. It's wonderful to be discussing these things with the very senior and or upcoming oncologists. So I hope this is going to be a fun session. I would request Dr. Manu and Rajalakshmi to watch the chat.
Sure, ma'am.
Right? Yeah.
Sure.
So that we don't lose time, and I'd like a lot of interaction so that then it's going to be useful for everybody. Right. Moving on. What we are going to do is in the following few say 30 minutes or so, we are going to be learning how to prescribe step 2 analgesics correctly. We also are going to look at converting from step 2 opiates to step 3 opiates. We are going to look at changing from fentanyl to morphine and vice versa, and similarly with buprenorphine. We are also going to look at how we can change from immediate release morphine to sustained release morphine to other alternative modes of administration, and a look at a few real life scenarios. Let's move on. So first case study for today is Mrs. R. She's a teacher in a local school. She presented to our OPD with an ulcerated nodule in the right breast since a week. She reports intermittent pain with a maximum pain score of 5 to 6 over 10. She has no comorbidities. She weighs 40 kilos and her labs are normal. She drives a two-wheeler to work, she informs us. She is not on any analgesics. What I want to know from the participants is how would you like to manage her pain and how would you be giving her a full prescription for the analgesics that you have planned for her? please answer in the chat box. I'm going to give you about 30 seconds to a minute to type in the full prescription. Or possibly if you want to unmute and answer, that's also okay with me. What do you think, Dr. Manu? We can do that as well.
Yeah, either way, fine, ma'am. Those
Yes.
who want to type, they can type also.
Yes.
Ma'am, Dr. Asura has written, start with weak opioids.
Start with weak opioids. Can you be more specific, sir? Can you be more specific? Which opioid are we talking about here?
Dr. Asura, do you have any more answers for that? Ma'am, we have one more answer by Dr. Ravi Kiran. It says
Okay.
tap paracetamol 650 milligram QID.
Okay.
And tap tramadol 50 milligram TID.
Okay.
Tap metoclopramide TID 10 milligram TID.
Okay.
And syrup cremafin is written.
All right. Any more volunteers?
Ma'am, Dr. Azura has written tap tramadol 50 milligram BD.
50 milligram BD. Okay. Okay. Is that his full prescription? Do you want to add anything else when you are prescribing tramadol? Any
Ma'am,
answers?
one more. Yeah,
Yeah.
ma'am, one more tramadol 50 milligram BD. But in the previous answer, Dr. Ravi Kiran had written including metoclopramide also. And dressing, he has written dressing also, wound dressing.
Wonderful. Wonderful. So, anybody else wants to give it a go, or shall we move on to the answer?
Yeah, more answers regarding cleaning and dressing, evaluation of breast nodule.
All right. All right. Yeah. So, I think I should have made that clear in the beginning. So we are going to concentrate only on the analgesic prescription for the purpose of this, for the purpose of this discussion, because that's the main brief of our meeting today, right? So yes, of course, we are going to evaluate her. We are going to do, we are going to do a thorough psychosocial and spiritual assessment as well. We will be doing dressings. That is a given, but that is not the main brief for today's session. So we will confine ourselves only to the analgesic management. So I'll move on. Okay, for some reason, my screen is frozen. Yes. So let's see what Mrs. R's prescription should ideally look like. I would start with either tablet Ultraset, which is very commonly available in my institution. It may not be at yours. So capsule tramadol is just fine. We don't have tablet tramadol. We have capsule tramadol. And I would start with one tablet every 8 hours. I can't really quarrel with the 12th hourly prescription also, provided you want to assess the patient again within 24 hours to find out whether she's relatively pain-free and her pain score is definitely coming down. Otherwise, I would like to go with the Q8 hourly. She's a young, fairly middle-aged lady. She is, working at a school. We would like her to be fairly comfortable. Right. Now, for those of you who only mention the analgesic, when we start weaker opioids, it is important to also, whether weak or strong, we would like to give them a breakthrough dose. So I noticed that none of you had mentioned the breakthrough dose. So when we write a regular analgesic, we also want to tell them, in case the pain is not getting controlled, you would like to ask them to take one more tablet of the drug whenever there is pain. And it should not be any more frequent than 1 hour. So they should not repeat that dose within 1 hour of taking the first dose, right? Now, they can go up to a maximum of 8 tablets per day. This is instruction that you would be giving anybody, no matter what medications you are prescribing. You also should be giving an antiemetic. People had mentioned, I think Dr. Asuran had mentioned metoclopramide, which is fine. That's perfectly all right. I use more domperidone at my institution, but that's perfectly okay. It's just personal preferences. One is not better than the other, except in a few situations. So 10 milligrams Q8 hourly for 3 to 5 days. When we mention the drug, please mention the dose, please mention the frequency and the duration of the prescription. And then after 3 to 5 days, if the patient no longer suffers from that complaint, they can choose to take it only when necessary. This will be followed by a stimulant laxative. Do we all remember from our previous sessions that opiates cause constipation and mainly they affect the motility more than the consistency of the stools produced. So we would like to add a stimulant. Whether we like to add a softener or not is a matter we can take up later, right? If the patient says that I'm having hard stools, you can add the cramafin, which is primarily a softener later. And with a weaker opioid, I would normally tell the patient, please take 1 or 2 tablets depending on the patient's bowel movement. Everybody's bowel movement and pattern is different. So sometimes if you go and give 10 milligrams to somebody, they have an unnecessary diarrhea and they get very scared and they totally stop the laxative. So please be mindful of that. Is there anything else that you would like to tell this patient? I particularly put in the last slide there. I just go back there. She weighs 40 kilos. Her labs are normal and she drives a two-wheeler to work. Are you going to tell her anything else?
Ma'am, tramadol does cause drowsiness at times. So she should be cautious of the dosing and her driving.
Excellent. Is that Dr. Ravi Kiran
Yes, ma'am.
who spoke? Wonderful, wonderful. That's a very astute observation by you. And so how long should she not drive? Is there any such, rules in
Uh,
place?
Maybe the dosing time can be changed as per the, if she working like you goes at 8 a.m. or 9 a.m. better she can take the tablet after driving reaching the workplace and increase the dosing according to that. This could be for 1 to 3 days max at times till the body just accustomed to the this thing, and then she can slowly observe what is happening even post 3 to 5 days. Even she reports heavy drowsiness with the dosing, then we can substantially reduce the dose in the morning and increase at the night time, depending upon the person response.
All right. So I take your points. One needs to put it in place and see whether that's going to work out. But the main bottom line here is that we are going to instruct our patients, whether we're putting them on weak opioids, any other sedatives, antidepressants, anti-epileptics, or stronger opioids, or any patches for that matter. We need to tell them that they're going to feel drowsy. They may feel giddy, and not everybody goes through that, but most people do, and that they must not drive for at least the first week of therapy. So the important thing here is we need to establish analgesia first, right? So we can't tell her to juggle the analgesics in the first 3 days because we need to get it to work, right? And we all know that the sedation is a self-limiting problem, right? So what we will do is to ask her to refrain from driving for at least 1 week, and thereafter she must, go on empty roads initially, go in the daytime, make sure that she's feeling all right before she actually takes a vehicle, or she should be at least accompanied by somebody who can take charge of the vehicle in case she's not feeling good. So this is mandatory, right? More and more patients are being on such medication, so we need to discharge them with this. Is everybody clear as far as this prescription goes? Are there any doubts here? Or can we move on? Anybody?
Yeah, ma'am,
You can,
it's written
yes, yes.
clear. It's written. Yeah.
All right, we'll move on then. Thank you. A few months later, we are still with Mrs. R's story here. Mrs. R has come to the oncologist. She has a mild headache since a couple of days, and it's subsiding with paracetamol. And the pain in the ulcerated nodule is very well controlled with 6 hourly dose of tramadol. She takes 1 or 2 rescue doses sometimes. She has stopped domperidone because she no longer feels pukish, and she's taking bisacodyl, just 1 tablet at bedtime. Unfortunately, her CT brain has shown a solitary lesion in the frontal lobe, and the radiation oncologist has planned whole brain RT. Do you want to change her prescription, or you want to add to the prescription? Any ideas? Fire away.
Ma'am, we'll change the prescription straight away.
All
The
right.
patient has the brain metastasis. So definitely the tramadol, or the tapentadol, which usually decreases the seizure threshold. So definitely we do avoid in such patients, and we add steroids in this case as we plan RT, along with the oral or the IV, depending upon the patient profile and the OPD IPD values. And paracetamol we do continue for the 6 hourly dosing.
Wonderful. Wonderful. Anybody else wants to add on something? So we are going to stop the tramadol. We are going to add dexamethasone. We are going to add the paracetamol. Are we going to continue the bisacodyl? Any thoughts on that?
Dr. Sunesh has written no,
We're not going to continue the bisacodyl?
not going to continue.
All right. All right. So we just hold it right there and let's see. So yes, tramadol, like Dr. Ravi pointed out very clearly, we will stop tramadol immediately. It can cause seizures when the dose exceeds 400 milligrams per day, or when it's combined with other drugs that can lower the seizure threshold, which would be your tricyclics. It could be, your gabapentinoids. So we wouldn't like to co-administer these drugs. So what is the maximum dose of tramadol?
And 400 mg per day on.
400 mg per day. All right. So that's great. Yes, the maximum dose of tramadol is 400 milligrams per day. All right. Now I'm going to have to request Dr. Ravi to mute himself, because all the other people in the party are having only fun. So let's put somebody else in the hot seat. You can volunteer, or I'll start choosing, which won't be fun. So
Ma'am, there are answers from other persons also, ma'am, like Dr. Gopikrishnan, Dr. Nasiba, Dr. Annie. They're all giving answers, similar answers.
wonderful, wonderful. Happy to see that. Okay. Now, can you tell me if we are going to use tramadol in a patient who has chronic kidney disease? Can we use it? Can we not use it? What are your ideas on that? Anybody, please unmute and, you can go ahead. Can we use it in chronic kidney disease? That's the question here. Tramadol. We're still at tramadol. Anybody? Any answers coming, Dr. Manu?
No, ma'am, not yet.
Okay.
Please, someone can unmute and tell.
Yeah, I've
Dr. Gopi?
disallowed Dr. Ravi. I'm sure he's very enthusiastic and he's going to answer. So
Can we use the dose reduction?
Tramadol can be used here because it doesn't involve with the nephrotoxic. It is not nephrotoxic, and I think we can continue with the.
all right. Dr. Gopi Krishnan, is that you?
Yes, ma'am. Yes, ma'am.
All right. So you think tramadol can be continued? We should have a vote on this, How many people think we can continue tramadol? Just raise your hands. And if you think we can continue tramadol, Dr. Gopi, I would like you to substantiate that. How are you going to justify that? Lot of people, I'm seeing a lot of raised hands here that we can continue tramadol. That's very interesting. Somebody can justify among the group who decides that they want to continue tramadol. Can you please justify why?
Ma'am, there are mixed answers.
Okay.
Most say yes to continue, but there are two different answers. One from Dr. Gushbu Jain. She's telling
Yes.
if creatine clearance is less than 30, decrease
Mhm.
dose of tramadol. One answer.
Mhm.
And an answer from Dr. Ravi Kiran that
Mhm.
with reduction can continue in CKD if we have no other options. And
Okay.
answer
Yeah.
maximum dose is 200 mg per day.
Who's answered 200 mg per day?
Dr. Khushbu Jain.
Wonderful, wonderful. So I think this round goes to Dr. Khushbu because the dose is 100 to 200 milligrams per day in CKD. If the patient has a creatinine clearance hovering around 30 ml per minute, probably you could go up to 200. But if the creatinine clearance is dropping at 10 to 10 ml per minute, end-stage renal disease, we would reduce tramadol to 100 milligrams per day. That's it. And why is that? Now, there are a lot of people in the audience, and I need you to be vocal because this is a learning session. So please don't, there's no ego, there's nothing, no shame in this. So why did you think we could give tramadol? How does tramadol act in the body? In other words, let's take it from the beginning. How does tramadol act in the body? Is it a prodrug or is it an active drug? What are your thoughts on this?
Dr. Srivastava has written liver metabolism.
Liver metabolism. Wonderful. Is it a prodrug? Is tramadol a prodrug? I mean, does tramadol, is tramadol active drug? What is it? Any thoughts? Anybody else wants? Dr. Gopi, Dr. Ravi, you all said that we are going to reduce tramadol. So why did you say that then? Dr. Khushbu? Sorry? I didn't hear you.
Ma'am, it's a prodrug. Ma'am, it is a prodrug. It goes metabolites. I forgot the metabolite of tramadol.
Never mind. Yes.
Yeah.
Okay. So yes, it is a prodrug. So tramadol is converted in the liver to O-desmethyl tramadol, which is the active component of the drug. Okay. It doesn't act otherwise. So it has an active metabolite. And it's finally excreted by the kidney. Now, if you have, decreasing renal function, this active metabolite is going to double up in the blood and slowly cause problems. It will accumulate and it can potentially cause seizures in patients who have reduced creatinine clearance. Is this point clear among all participants? Because it's vitally important that you understand that. On the same note, I've just told you tramadol is a prodrug. Now, can I use tramadol in a hepatic disease? Think on the lines of what I just told you. Can you use tramadol in hepatic disease? If yes, why? If no, why? Anything? Any thoughts coming up? Any guesses? Doesn't matter. You don't have to know the right answer, just guess. Dr. Gopi, Dr. Khushbu, anybody? Dr. Srivatsa, yes?
Dr. Manu, I think you're muted, sir. Can you unmute and speak?
Yes, yes. Ma'am, there are different answers coming here. Dr.
Yes.
Ravi has written the maximum dose reduction, and Dr. Arun has written so. Dr. Sunish has written yes, but the potency may be less. Dr.
Okay.
Kushbu has written tramadol will be less effective. Dr. Amit Rana has written don't use as toxicity is increased. Dr. Srivat has written can be used based on stage of liver failure. And Dr. Neetu has written yes, but less effective. And Dr. Gopi Krishna has written as it involves liver metabolism, dose has to be increased.
All right. All right. So, so the scientific answer here would be that if the patient has got mild hepatic impairment, where you don't expect the CYP2D6 metabolism to be affected, which would be a patient typically child pugs A, okay, mild hepatic impairment, you can go ahead and use tramadol. Sometimes you might have to increase the frequency from 6th hourly to 8th hourly, depending on how the patient is behaving. But in a patient who has got moderate or severe hepatic impairment, that is a definite contraindication to use tramadol. All right. This is the evidence, right? Also, we must remember that when tramadol is used with MAO inhibitors, SSRIs, SNRIs, we must remember that there is a risk of serotonin syndrome. All right. So with this, we are going to move away from tramadol. Are there any questions over the points that we have been through so far?
No more
Anybody?
questions.
Okay. All right. Wonderful.
Ma'am, regarding
Yes.
tramadol, one question. The usage in patient with QT prolongation and tramadol.
QT prolongation and tramadol. I don't think it's much of a problem, but I can look it up. I can't give you a pinpoint answer. I have never come across QT prolongation as being a problem in tramadol.
Ma'am, after the session,
Prescriptions.
I have two doubts regarding this because I have a case with a patient. After your session, the doubts plus I will talk about that case, which which going to come tomorrow again for the consultations. I need that.
Sure. We can take it forward. All right. Thank you. So coming back to Mrs. R, now we have decided as a team that we are not going to prescribe her tramadol because it's going to lower her seizure threshold and all of that. So which analgesic do you want to switch to? Come on, this is an easy one. 5 seconds for this. Which analgesic do we want to move to? Come on, guys and girls. Which analgesic? No answers? Oh gosh.
Dr. Amitrana is written acetaminophen. Dr. Ashwini has written paracetamol. Paracetamol again. Dr. Neetu, Dr. Govind, Dr. Nasiba all for paracetamol. Dr. Vivi has written steroids. And Dr.
Steroids.
Azura written paracetamol. Dr. Gayatri for steroids.
Okay. So, going back to Mrs. R's history, she had a pain score of 6/10, 5 to 6/10, and it was well controlled with one opioid, tramadol. She was nearly taking how much of tramadol? 50 milligrams Q6 hourly, 2 rescue doses. And now you're just going to stop all of that because of the seizure potential. And this is a theoretical seizure potential. And you're just going to put her only on paracetamol. And dexamethasone is not going to last too long. I mean, I didn't even say that she has brain edema. So whether I want to put her on dexamethasone is, variable. I might want to put her on Dexa when she goes for whole brain RT. Maybe I won't even want to start her because she is displaying only one sign of mild headache, nothing more. So do you want to rethink this?
Ma'am, we have a few answers. Dr. Arun
Yes.
and Dr. Leah, they're telling morphine. And Dr. Annie Francis has written tapentadol.
All right. To Dr. Anne Francis, I would just like to say that tramadol and tapentadol are a little similar to each other. And at this point, we don't have a lot of studies on tapentadol. So we will refrain from using tapentadol and tramadol in any patient with suspected intracranial metastasis or raised ICP or head trauma. So tapentadol is definitely a no. And to the others, I'm sorry, I can't recollect all your names, but yes, morphine is the correct answer. Definitely, you are going to switch this patient onto morphine, right? And we will be going to oral morphine. All right. Now, what dose of oral morphine would you like to give this patient? Shall I start at 5? Shall I start at 10? 4th hourly, 6th hourly? What do I want to do?
Ma'am, Dr. Arun has written 5 mg 4th hourly. Other answers also, Dr. Azur has written 5 mg 6th hourly. Dr. Gobi for morphine 5 mg 4th hourly. Dr. Ravi Kiran has asked about morphine, but I'm still doubt does metastatic brain headache response to morphine. And two more answers. Dr. Nasiba and Dr. Vinod Kumar both for 5 mg 4th hourly or 6th hourly. Amit Rana has written 5 mg 4th hourly.
Okay. And what is the rest of your prescription going to be? Just 5 mg 4th hourly? That's enough?
Ma'am, first we convert the tramadol dose to morphine based on the conversion factor, which I suppose 1:10. I was not much sure of it. Based on that conversion, initially we can start a 5 mg morphine trial and then look into the side effects and the dose response. And also we can convert the same thing based on the prescription, as we said, the paracetamol 650 Q6 hourly, morphine based on 1:10 or 1:5. I'm not sure of the conversion factor, ma'am. Based on the 5 mg Q6 hourly, and also based on the response of the oral morphine, and then we can start with the antiemetic of choice, either haloperidol or metoclopramide, and a laxative as bisacodyl, 10 mg 2 tabs at night because it's of morphine. And then along with co-analgesics, and we re-evaluate the patient further. Based on Wolbran RT, she comes the.
All right. Sounds fair enough. So how do you decide the dose? So Dr. Ravi has already answered that question for the audience. So first is we calculate the total daily dose of tramadol. So this patient was receiving 50 mg Q6 hourly, which works out to be 200 milligrams with 2 rescue doses, which works out to be 2 into 50, 100 mg. So we have a total of 300 milligrams of oral tramadol per 24 hours. Now, what you do is you go ahead and divide this by 10 because our conversion factor for practical purposes from oral tramadol to oral morphine is a factor of 10. So you divide that by 10, the 300 milligrams by 10, and you are left with 30 milligrams of oral morphine in 24 hours. Any doubts here? Actually, with this conversion, originally was for intravenous morphine. For oral morphine, originally the conversion, in fact, in some places, it is 5, 1 by 5. However, what we have noticed, and literature also says that 1 by 10 works just as well. It's just simple for everybody to remember, and it's universally practiced even in the West. So 300 mg divided by 10, you've got 30 milligrams of tramadol, of morphine. And we've already heard from Dr. Ravi that, and number of others who said tablet morphine 5 milligrams Q6 hourly. So basically, you're going to divide the 24-hour dose of morphine of 30 mg into 6 doses, and you're going to give her 5 mg Q4th hourly and 10 mg at bedtime, so that she doesn't wake up in the morning at 2 a.m. to have the 6th dose. You're also going to give her, I beg to disagree with Dr. Ravi there. I would not like to give her perinorm. Perinorm crosses the blood-brain barrier. It can cause involuntary limb movements. It can cause, extrapyramidal symptoms. So again, I would not like to use that in a patient with intracranial lesions. I would stick with good old domperidone. Most likely, she's not going to require it. We'll continue the paracetamol, and yes, we would like to continue the Dexa as well. And yes, I would give her bisacodyl 10 mg at bedtime. Right? And I would also prescribe something else. Do you want to give her an SOS dose of morphine as well? Like I told you, the first example, we are also always going to give her an SOS dose, right? She's somebody who's already opioid tolerant. She has taken tramadol before. So we would like to give her, extra dose of morphine as and when she finds it necessary. right? So that morphine will be given 5 milligrams Q 4th hourly, 10 mg at bedtime, and you will add a SOS dose of 5 milligrams whenever the patient requires. Are we clear so far?
Ma'am,
Ma'am, doubt. Ma'am, 5 mg 4th hourly, that comes around 30 mg
6.
plus 10 mg equals 40 mg, no, ma'am?
No, so when I say 5 mg Q 4th hourly, our instructions would be that you take that 5 mg. Normally in our setup, what we do is first dose of the morphine for the day will be at 6 a.m. Okay, so 5 mg at 6, 5 mg at 10, 5 mg at 2 p.m. in the afternoon, 5 mg at 6 p.m. at night, at the evening, and 10 mg directly at bedtime at 10 o'clock. So
Okay.
all that together works out to be 6 doses totally, and that would be 30 mg.
Okay.
So the 10 mg is not over and above that Q 4th hourly, right? The last dose is the double dose.
Okay.
And that is universally practiced so that the patient doesn't lose sleep trying to get up at 2 a.m. Okay.
So, ma'am, what is the rationale for giving double the dose at night time?
So that they sleep through and they will not, they will not be, losing, getting up, and the sleep will get all fragmented. So I understand that there is this theoretical concern that, whether I am giving 5 milligrams or 10 milligrams or 20, it's going to last only 4 hours because the plasma half-life is 4 hours. So, but what we have practically seen is normally patients, if they are comfortably sleeping after the 10 o'clock dose, they don't get up in between and they just wake up at 6 a.m. to have the next 5 mg dose.
Okay.
Right? But there are centers where what they do is they give the immediate, instead of immediate release morphine, they give the sustained release morphine at 10 o'clock, which will go on right through the night till the patient wakes up. But I have seen both. It works fine. I personally, I'm continuing to practice 10 mg at bedtime. But if I find that the patient is very groggy, they are waking up very late at night, late in the morning. Sometimes they say, I don't even wake up before 8 o'clock. I'm missing my 6 o'clock dose all the time. I actually give them only 5 mg at night. But these are individual, variations which you will change from patient to patient as you become more comfortable using the drug. But for the purposes of the class, I would like you to take home this message that usually the bedtime dose is double of the 4th hourly dose. Have I made myself clear, Dr. Sunish?
Yes, ma'am. Thank you.
All right. Moving on. So where are we with Mrs. R's story? Whole brain RT was completed. She became fairly comfortable on tablet morphine, and she actually needed 10 milligrams Q 4th hourly for over 20 days. Sorry, I forgot. There was a comment in the previous discussion about that, whether really do you need 10 mg morphine for just a mild headache. So just to, recapitulate, she also has her breast lesion right there, which was very painful. Only the headache was mild. The breast lesion was requiring moderate level of analgesia. All right. I don't remember who asked that question, but that was there. So moving on, she was taking 10 mg Q 4th hourly. That works out to be 60 milligrams of morphine per day. She used to take one rescue dose on and off, not every day. Now she wishes to know if she can go back to teaching, but she doesn't want to be taking meds every 4 hours. I mean, people in school will watch her and she's not comfortable with that. Have you any ideas on that? What can we do for her? Not Dr. Ravi. Dr. Ravi is going to be muted for some time. Dr. Neetu, Dr. Nasiba, Dr. Kushbu, Dr. Gopi, Dr. Sunish.
Yes, ma'am.
I know only
Dr.
these many names. Yes.
Yeah. Dr. Kushbu, Dr. Gopi, Dr.
Mhm.
Nasiba Till, Dr.
Yes.
Gayatri written sustained release morphine.
Wonderful. Sustained release morphine, full marks to you. So sustained release morphine, what dose? What dose are you going to give her?
And Dr. Nasiba has written 30 mg BD.
30 mg. So morphine, SR, you must mention all this in your prescription. Okay. If you just write morphine plain, no, that's not going to work. Morphine, SR, 30 milligrams twice daily. All right. Do you want to give anything else?
Ma'am, Dr. Sunish has written, can we give double dose 8th hourly instead of probably instead of sustained release?
A double dose 8 hourly. So you want to do 20, 20, 20? Yeah.
Yes, ma'am.
That's interesting. We are saying that it's going to work in the night. So why shouldn't it work in the day is your contention. Honestly, I've never done that. And scientifically, we would be wrong doing that. You know, during the day, you pop in 20 mg of morphine, you'll be zonked. You're not going to be able to function. At night, that's fine. You want to be, you want to pass out and sleep, but not during the day.
Okay.
So no, you won't be doing that.
Ma'am, one more answer from Dr. Akhil. PRN dose also to be given, plain dose.
Wonderful.
Plain.
That's what I was waiting for. Yes, a plain dose of morphine. And how much, Dr. Akhil?
It will
How
be
much
usually
of-
5 mg or 10 mg. Yes.
It will be 5 mg or 10 mg.
Yeah, it will be 10 mg. 10 mg usually because it is we are giving 60 milligram. The PRN
Yes.
dose should be at least 1/6 of the total dose.
Excellent. You made my job easier.
Total daily.
Wonderful. Wonderful. So Dr. Akhil has nailed that one totally, along with Dr. Kushbu. Am I right, Dr. Kushbu, or have I got the name wrong? I'm sorry. No offense meant if I've forgotten somebody else's name who said the answer. So SR morphine dose is the total IR morphine consumption in 24 hours divided by 2. And it will be given in 2 to 3 divided doses per day and never more than 4 doses of sustained release per day. Please remember that. I mean, this is a simple example. There'll be other patients who have different, total morphine doses. So you'll be tempted to give more sustained release morphine through the day. Remember, never more than, preferably not more than 3 doses per day, and definitely not more than 4 doses. It will accumulate and cause toxicity. So our prescription is, yes, sorry.
Ma'am, Dr. Ravi has asked, ma'am, in our institute, we don't have 30 mg SR. Can we give 20 mg SR, TAD
Yes,
plus 10 mg?
definitely.
Yes.
Definitely. You can give 20 mg SR, TID along with the immediate release morphine, 10 mg for SOS. Perfectly all right. So there we go. And we don't forget the laxative. We don't forget the SOS antiemetic. Of course, this patient is used to morphine, but we don't like to forget the antiemetic SOS. So patient should always have these, these drugs in hand. All right. We don't like to discharge them without that. Wonderful. Now, I have a question to the audience, just digressing from this patient. Assume that we are treating a patient with, who's got a GI malignancy or a head and neck malignancy, and they have a feeding tube. Now, can I use sustained release morphine in a patient with feeding tube?
Dr. Ravi has written, no, ma'am.
Okay. Anybody else wants to give it a shot and tell me why no?
Yes, Dr. Ravi has written, it cannot be crushed. That's why. Dr. Kushbu also, again,
Agrees.
same answer. Dr. Arun, again, no. Dr. Akhil has written, plain morphine can be used. And Dr. Kushbu has written, as it has coating.
It has a coating. It is enteric coated. Any enteric coated tablet should not be crushed and put into the Riles tube because it would be released. All of the 30 mg of morphine will get released into the system, and the patient has a danger of getting over sedated and probably even depressing their respiration. So we must be very conscious when patients have feeding tubes. We do not prescribe them sustained release drugs. Okay. How about bisacodyl? I mean, this is off the track, I know, but while we are at it, how about bisacodyl? Can I crush bisacodyl and give it through the Riles tube? Any answers?
Dr. Akhil has written no benefit of crushed bisacodyl.
Yes, it doesn't act because, again, bisacodyl is enteric coated. It's supposed to act only in the colon and the rectum and not higher up in the GI tract. It can cause more colic. So if you are going to have a patient with a feeding tube, be cognizant of that. Do not prescribe, bisacodyl because you're not supposed to crush it and use it. You would like to give them maybe a Cremefin Plus, where you have this liquid formulation of sodium picosulfate, which is also a stimulant laxative. Okay.
Ma'am, we have other answers also. It can be
Yes.
given PR, and it can be bisacodyl as suppository, or suppository can be given. Answers by Dr. Ashwini, Dr. Arun, Dr. Kushbu.
Okay, to Dr. Ashwini and Dr. Kushbu and Dr. Arun, bisacodyl suppository is not the first line. So, can you imagine the problems that patient might have? You know, if they had to put in a suppository on a daily basis or even every other day, it's not very aesthetic, isn't it? We wouldn't like to do it. Oral laxatives are the first line of therapy. Rectal laxatives come second, only when the oral is not working, or you have other problems like, spinal cord lesions or something like that. So rectal laxative is not first line. So definitely it is our duty to give them a oral laxative, which is feasible through the Riles tube or any other feeding tube. Okay.
Thank you, ma'am.
Moving on. Patient is still with us and she has returned to the hospital. This time she is complaining of poor appetite. She has vomiting. She has vague upper abdominal pain. She's unable to keep this morphine down. And you're seeing her in the ward. The labs have been sent. An ultrasound abdomen has been ordered. Meanwhile, she's having pain and vomiting. Are we going to manage this? We are at 7:46, so we really need to move on. So quick answers, please. Not Dr. Ravi. Dr. Ravi, I am requesting him not to answer. Dr. Kushbu, Dr. Neetu, Dr. Nasiba, Dr. Arun, Dr. Akhil, Sunish, Dr.
Sunish
Dr.
has written
Gayatri. Yeah, Dr. Sunish.
injection morphine and IV morphine by Dr. Nasiba.
Okay, so you want to, okay, IV morphine. Yes, wonderful. Where we are going to give parenteral morphine. All right. Only IV? Is there any other route we are interested in? Anyway, we'll come to that. Okay. So, yes, you have a plan. You have told me you are going to use IV morphine, but you haven't told me how much.
Ma'am, there are other answers also, like subcutaneous morphine by Dr. Annie Francis, Dr. Gopi, and
Wonderful.
Dr. Kushbu, transdermal patch. Dr. Leanda Tamara has written fentanyl patch, and Dr. Shraddha has written metoclopramide with IV morphine, and Dr. Sunish has written 1/3 oral dose.
All right. So Dr. Sunish has the dose correctly, 1/3, and many others have responded as subcutaneous morphine. That's perfectly fine. Yes, we could move to a fentanyl patch. That's an option. But I will just keep aside the fentanyl patch for a brief moment. Let's get through with the parenteral morphine and then we'll come to the fentanyl patch. And after that fentanyl patch discussion, I'm going to ask you if you have changed your mind. Okay? Right. So yes, everybody has got this one right. We are going to use IV morphine at 1/3 the dose. So we were at 10 mg of morphine. So we are going to use now 3 milligrams of morphine, same every 4 hours, and 3 mg IV SOS. Are we all on the same page? Is this okay? This prescription okay for everyone? All silence. Yeah?
Everyone is typing, it seems, ma'am.
Oh, okay. Okay.
Yes, ma'am, it's coming up. Yes, yes.
All
Dr.
good?
Sunesh, Dr. Yeah, all
Yeah.
good, ma'am.
Wonderful. Now, somebody had mentioned IV perinom. So I really like it that you have addressed the vomiting issue here. But like I said previously, I would be very wary of using IV perinom. Now, remember that Mrs. R is somebody who had intracranial metastasis, right? Now, I don't want to give her IV perinom. Do we have a better choice? Can we give her something else?
Ma'am, Dr. Gobi has written no IV perinom. Dr. Ravi has written injection haloperidol. Dr. Annie has written steroid. And Dr. Akhil has written EPS, very common with IV perinom.
Excellent. Yeah. So we don't want to give IV perinom. I think we are all agreed upon that point. And yes, I would agree with Dr. Ravi there. We would like to give her IV haloperidol. It's a perfectly logical answer. As far as IV DEXA goes, yes, I mean, as an antiemetic primarily, do I want to use DEXA upfront? Maybe not. But if her liver pain is not going to settle down with just morphine, and I'm suspecting that there's a huge met or multiple big mets which are stretching the liver capsule, yes, I would like to add DEXA, which would have a dual effect of both analgesia as well as anti emesis in that situation. So yes, we will give her IV haloperidol at the dose mentioned. I would start somewhere at 0.5 milligrams BD or go up to 1 mg BD depending on the patient. And you could repeat this PRN 0.5 mg to Q2 hourly SOS can be given till we decide what is the dose, but we will not exceed a maximum of 10 milligrams per day, right? Now, let's consider a hypothetical situation where you don't have an IV line, and you already answered this one by saying that subcutaneous route. I think Dr. Anne had answered this, and somebody else also, that they had mentioned the subcute route. Now, how much do you want to give? You don't have an IV line, so what are you going to do?
Ma'am, Dr. Annie and Dr. Gopi both have written subcutaneous route.
Okay, Dr. Anne and Dr. Gopi, can you tell me, Dr. Annie and Dr. Gopi, can you tell me how much of subcutaneous morphine would you like to give this patient? What is the dose conversion, in other words? So we are at oral 10 mg of morphine. That's where we were. How do I give it subcutaneously? Shall I just give the same 3 mg? Will that be all right?
Same dose it's written. It's Dr. Sunesh and Dr. Annie.
Same dose. You mean 3 mg? That's or are you meaning 10 mg?
Same as IV dose, ma'am.
Same as IV dose. Okay. Small. I beg to disagree here. So the dose conversion from per oral to subcutaneous would be 1/2. Okay. Instead of 1/3 for IV, it will be 1/2. All right. So in this situation, we would be giving oral morphine dose divided by 2, which is 5 milligrams Q4th hourly with 5 milligrams SOS subcutaneously. Did everybody get this? You just divide the oral dose for oral 4th hourly dose by 2. Okay. For haloperidol, it will be the same dose, actually. the same dose by the subcutaneous route. It's only for morphine that we have changed it. Can we move on?
Yes, ma'am.
All right. So Mrs. R's results have come. She's developed liver secondary. She's mildly icteric. Her pain has settled somewhat, but she's unhappy to swallow tablets and she also wants to go home. So you can't send her with an IV line. She's not so keen on the subcute either. Now what? You already answered this one actually. Somebody had also already mentioned it up front.
Dr. Nasib has written fentanyl patch.
Fentanyl patch, yes. Yes. So, Dr. Nasiba, how much fentanyl would we like to give this patient?
And Dr. Kushbu and Dr. Leanda, they also had mentioned fentanyl patch, transdermal patch.
Okay, so the question is open to all three of you now. How much fentanyl are you going to give her?
Dr. Akhil, Dr. Gayatri also had a patch.
All right. So we are all agreed upon fentanyl patch. And I'm sure we all agree that's pretty expensive. But for the purpose of this discussion, yes, we are going to try to give her a fentanyl patch because that's appropriate here. And but none of you are coming up with the dose. So what is the conversion? Everybody's thinking that's why you're taking the class. So why don't you figure it out?
Dr. Sunish has written oral dose by 2.
Oral dose by 2. So are you saying I'm going to give her 5 milligrams of fentanyl? Or I mean the total dose, or you're saying I'm going to give her 30 mg of fentanyl?
Patches are available at a dose of 12.5, 25, like that, ma'am.
All right. So, so Dr. Sunish, is that you? Yes. Dr. Sunish, I would like to, I'm not going to, so yeah, what I'm going to ask you is, tell me what is the dosage of the patch? You said 12.5, but that's not a complete answer. What are the units?
Microgram per hour.
Microgram per hour. And what are the units on your morphine?
Milligram.
Okay. So tell me, how are you going to convert this?
If the patient is settled on 30 mg of morphine, we can give around 12.5 mcg per hour patch for every 72 hours.
So how did you convert? You just did 30 by 2 because that's 15.
Actually, we don't have exactly the dose conversion. So
Okay. Okay. So yeah, that's why we are all here in this class. But I'm glad that you've noticed the units. That's great. You've got the conversion correct. So except that we don't know how we did this conversion. So yes, let's look at this. 24-hour dose of morphine for this particular patient, of course, was 60 milligrams, right? So 60 milligrams, just multiply it by 10, and you will get the total dose of fentanyl for that day. So 16 to 10, 600 micrograms of fentanyl in 24 hours. So the transdermal patch is an hourly release. So we just divide 600 by 24. You get 25 microgram per hour of transdermal fentanyl. And this patch lasts for how many days?
$72 hours.
Wonderful. Dr. Akhil has answered that. It's 72 hours.
Ma'am, Dr. Niba, Dr. Gayatri, Dr. Gopi, Dr. Annie, Dr. Kushbu, all have written 3 days or 72 days, 72 hours. So,
wonderful. I completely agree. But what I want to know from all of you is, have you understood this dose conversion? Are you all clear on this dose conversion?
Ma'am, please repeat once. This,
yes. So first our patient, let's start from our patient. Our patient was on 10 milligrams every 4 hours, right? So she's taking 6 doses of 10 mg, which is 60 mg for 24 hours. You multiply that 60 mg for 24 hours by a factor of 10. You will arrive at the total micrograms of fentanyl required per day. That is 60 into 10, 600 micrograms per day. A day has 24 hours. So 600 divided by 24, which is equal to 25, is the dose, is the strength of the patch that you will apply for this patient. 25 microgram per hour of transdermal fentanyl is the answer. Is that clear, Dr. Akhil?
Yes, ma'am.
Okay, so for tramadol, you are just dividing by 10. For fentanyl patch, you're multiplying by 10. Okay, just to keep it, just to keep it simple. It's just a factor of 10 that we are going to remember for both these drugs. One is division, the other is multiplication. One is milligrams, the other is, of course, micrograms. Okay. Now, somebody up front, I remember maybe Dr. Annie and Dr. Gopi, somebody else also said that we are going to apply transdermal fentanyl patch for Mrs. R that time itself, instead of going for IV or subcute. Okay. Now, when does this patch, once you apply, when does it start acting?
After 4 to 6
And
hours minimum.
peak action comes after 8 to 12 hours. So initially the patient might not get a pain relief, but after 12 hours, the patient will definitely get a pain relief.
Okay, so in our situation, was transdermal fentanyl an option when she's in the ward? Or would you still want to, give her parenteral and then move her on to transdermal?
For the initial pain relief, she could be given the parenteral dose. Then we can switch to transdermal patch.
Right. So the point I want to make here is that it has a certain latency period. It doesn't act immediately. That's the reason why we don't give it to opioid naive patients or patients who have unstable pain, because it has a latency period of 12 hours before it's going to show its action, right? So those 12 hours, the patient should not be suffering in pain, and you need to cover with immediate release drugs, be it by the oral route, or in our patient's condition, the oral route was not available. We had to rescue with IV or subcute. Do I make myself clear here? Yes, latency is something which we need to remember when we apply a patch. And we also need to remember the same latency will work when you take off the patch. It will continue to work for 12 to 24 hours. So you need to be very aware of that. Okay?
Okay, ma'am.
And when you apply a fentanyl patch, would you like to give them any rescue dose? Or we don't have to give rescue dose. Anyway, it's releasing 25 microgram per hour. Anybody wants to give a rescue dose? If so,
Dr. Sunil,
what is? Yes.
Dr. Suresh and Dr. Akhil written, yes, RD dose needed.
RD dose needed. Okay. And what is that RD dose?
Answers are yet to come, ma'am.
Okay. Few seconds. It's already 8 o'clock. I don't want to keep you all from dinner. So in the interest of time, I'm going to answer that one. We will be giving immediate release morphine, the same dose at the previous time that she was taking. 10 mg of morphine will be given as the immediate, 10 mg of immediate release morphine will be given SOS. Okay. And the first 12 hours of application of fentanyl patch, you will be giving the same 10 mg 4th hourly. After 12 hours of application, this dose will become SOS. Is it clear or are you confused? So the patient is having a transdermal fentanyl patch of 25 micrograms per hour. The first 12 hours, you have to cover her analgesia by giving her 10 mg of immediate release morphine every 4 hours. Once the 12-hour limit is crossed, the 10 mg morphine immediate release will become SOS. Any doubts here?
No, ma'am, no questions.
Okay, so please be aware of that. Now, patient with hepatic or renal failure, can we use fentanyl patch? Already I said in opioid naive patients and patients who have unstable analgesia, we are not going to use fentanyl patch because it's got a fixed dose release. It has a latency period. You need a rescue dose, all of that. It's not as fancy as it looks.
Ma'am, Dr. Suresh has written hepatic, we have to be cautious. And Dr. Ravi has written, yes, ma'am.
Okay. So both in hepatic and renal failure, we can use fentanyl because mercifully it doesn't have active metabolites. Of course, in severe hepatic impairment and the patient is very sedated, then I'll be little wary of using transdermal fentanyl because after you remove the fentanyl, if the patient is very drowsy and you want to remove the patch, it's still continuing to, the skin depot will keep on releasing for the next 12 to 24 hours. So that can be a little tricky. So remember, when you use fentanyl patch, though it's very convenient for some reasons, you should remember that in a sicker patients, when they are close to death, if they are very cachexic, they are febrile, the weather is too hot, it's not the best drug. It's not the best preparation. It's a good drug, but it's not the best preparation to use. All right. And please remember, when you are having transdermal patches applied to the body, they must be removed before you can go for an MRI scan. Okay. They can start conducting electricity. So you must remove transdermal patches before you go into a scanner. You must educate the patient on these things because just frequently they may be going to more than one doctor and they may undergo imaging without our knowledge. So you must tell them when you prescribe such things. And always the international standard is that when you prescribe patches, please prescribe not only with the generic name, but also the company name, because there are different kinds of patches in the market, matrix patches and other patches, which, there may be some mild alteration in the way they function. So please mention which company that they need to get if you are not going to be dispensing it. So we'll move on. This is Mr. J's story, and he was a patient with, I had treated with adult leukemia. Unfortunately, his disease was not very stable. He was having severe pain. I mean, we were getting calls right, left, and center from the ward, and we had been madly escalating morphine. Normally, we would do only, once every 24 hours, but with this patient, we were going ballistic. And until one day when I went for rounds, his wife tells us she's seeing some jerking movements in his leg when he was sleeping. What do you think the situation is? What have we landed in? We have 6 minutes to 8:15. So that was the time given to me. So,
Ma'am, Dr. Sunesh has mentioned myoclonus. Dr. Ravi also agrees with it.
okay. Anyone else wants to give it a chance? Very happy that you have recognized that. Somebody like his caregiver was very sharp and she could bring this to our notice. Yes, indeed, this patient was having myoclonus. And this is one of the neuroexcitatory side effects of morphine. When you rapidly increase, or the patient has having subtle electrolyte disturbances, or the kidney is packing up, or they are dehydrated, or sometimes they can even have coexisting delirium due to other medications they are taking, and myoclonus is setting in. So what is the treatment for this condition now? What do we do? This patient was fairly on a high dose of morphine. Usually it's seen with higher doses. Can be seen with lower doses as well, but mostly in higher doses, rapid escalations, that's when we see myoclonus.
Ma'am, answers are there. Dr. Nasiba written naloxone. Dr. Sunish has written benzodiazepines.
Right. Dr. Nasiba, if you're going to give naloxone to this patient, I already told you this patient was having difficult pain where we were having trouble controlling it. You would be completely reversing the analgesia. So I would be very wary of giving naloxone to him. I would go with Dr. Sunish here. What I would do is ask, I would reduce the dose of morphine, or I may even stop it if I have another alternative. I would hydrate the patient actively. And yes, if myoclonus continues to persist, and you definitely ask and observe how many episodes are happening per day, I would if it's not coming under control, I would use a benzodiazepine, either diazepam or clonazepam, one of those. So in this particular patient, what we did was we hydrated him, we stopped his morphine. Luckily, we had syrup methadone with us. In fact, he responded very well to methadone, and we transitioned him to methadone because he was on a high dose of morphine, and we couldn't not give him any analgesia. Transdermal fentanyl was not an option. It was beyond his capacity to fund that. So we moved him to methadone. Okay. Another story. Sorry. Yes. Sorry, Dr. Manu, I interrupted you. Tell me.
Sorry. Dr. Kushbu also answered methadone while you were telling that. Yeah.
All right. Great. So I'm glad we're all thinking on the same lines. Mr. M, he's a treated rectal cancer patient. He was treated outside, and he had come back. He had come to us with a local recurrence of his cancer, unfortunately. Some liver mets also, if I remember. No, or maybe not. No, not liver mets, just a local recurrence. His pain was, he was clearly, he was very clear in this aspect, because somebody had already, the oncologist had already prescribed him tramadol. He said he had no pain relief at all. My pain is 10 out of 10, I remember he told us, especially in the perineal region. He was transitioned to morphine. Unfortunately, he said after 2 days on ward rounds that he was having some urinary hesitancy. This gentleman was about 59, 60 years old. So urinary hesitancy, because he didn't have dysuria, but nevertheless, we sent off a urine routine. We did, looked at the residual urine. We did a PR and saw there was no prostate enlargement, no UTI. Even, the CT scan, the recent CT scan wasn't showing that, the disease had advanced locally, but it wasn't affecting the bladder so much. It was near the bladder, but it wasn't really impinging on it or anything of that sort. So what is our diagnosis here? And how are you going to treat this?
Ma'am, Dr. Leanda has written opioid-induced urinary retention.
Wonderful, wonderful. I like that answer. I think all of us will agree that that's what we were facing. He was not on amitriptyline or anything else, which was, which you should also remember. Somebody on other drugs which can cause urinary retention, you must remember that, you must check all the drugs in the prescription and see what is causing this problem. Yes, urinary retention. And what would we like to do for this, Dr. Leander?
I will decrease the dose and do the opioid rotation and maybe do the catheterization, ma'am.
Okay, So yes, if they have acute urinary retention, definitely you will have to salvage the situation by doing a catheterization. And secondly, yes, reducing the opioid dose. I guess I'm not sure that's going to help. Yes, but I would agree to opioid rotation because that's exactly what I did. And also, while we are on it, urinary retention is not very common with oral opioids. It's much bigger problem with um, neuraxial opioids, so intrathecal, epidural. So, urinary retention is a bigger problem in that situation. But this is one of my only cases where I have seen, I have used lots of morphine, both as an anesthetist and as a palliative care physician. And believe me, this was my first case of urinary retention. Okay. So yes, that is urinary retention due to opioids. And yes, what I did was opioid rotation. I didn't need to catheterize him. Mercifully, he was passing per urethra, smaller quantities with a lot of hesitancy. But, once we switched the opioids, he was all right. So another case, I think this is the last case.
Excuse me. Excuse
yes.
me, ma'am. Ma'am, there are two more answers. Like one is side effect of morphine urinary retention. One more answer by Dr. Kushbu that says Kori previous radiation. So that can also lead to the
So previous radiation causing urinary retention, is it? Interesting.
Yes.
Yes, I mean, previous radiation can cause, entrapment of the ureters in fibrosis. And but, usually the patient will not, I mean, usually what they come with is lumbar pain, dull aching lumbar pain. And when you take an imaging, you will see a bilateral hydroureteronephrosis or a unilateral hydroureteronephrosis rather than urinary retention is what I would say, because I really haven't seen somebody presenting just with urinary retention and us finding out that, patient had this problem because of radiation. Usually we see the hydroureteronephrosis first, and by which time, you're already going to stent it or you're going to do a PCN, nephrostomy, and they don't go into retention per se.
Thank you for that answer and sorry for the interruption, ma'am.
No problem at all. And I think this is my last slide because I think we are already at 8:17 and I'm so sorry that I've extended the time. Mrs. N, she was treated in our institution for Hodgkin's disease, and she had been prescribed morphine for a nasty backache. Subsequently, she had responded to chemotherapy very well. She went into remission, and she has been disease-free for over a year now. She was tapered off her morphine gradually, as we should have. However, she seeks morphine everywhere she goes. She comes to our OPD, she makes a big scene, she visits the ER with vague body ache and vague symptoms. She's visiting other hospitals as well, seeking morphine. She's frequently in conflict with us and her family members when we tell her that, she doesn't need morphine anymore. What do you think is happening to this patient?
Ma'am, addiction, that's an answer by Dr. Akhil. And Dr. Kushbu has written opioid withdrawal. Opioid addiction by Dr. Gopi.
So, Dr. Kushbu, opioid withdrawal, then I would be seeing much earlier because she has been tapered off morphine quite some time ago. So, withdrawal will be something more acute where, patient will be presenting with some hypertension, restlessness, tachycardia, sweating, pupillary dilatation, diarrhea. So, those are the symptoms I would see in acute withdrawal, right? But this patient is not showing any of those signs. So, I'm tempted to go with Dr. Gopi's answer. Yes, what she is displaying is inappropriate opioid use, and there is some psychological dependence. Actually, we are going to refer her. She's already working with our psychologists on that front. And we are also probably going to be having to refer her to a proper drug de-addiction therapist who's going to help her overcome this problem. Lastly, because this was part of the brief, I've showed you what is the conversion for buprenorphine. It doesn't go exactly like the other drugs that you just simply multiply and get an answer. Unfortunately, though there is a clear there is a clear conversion factor. I think with transdermal buprenorphine, it's a factor of 100. It's 100 times more potent than morphine. But but with various studies and the international practice is that a 5 microgram per hour patch is kind of like taking 12 milligrams of oral morphine in 24 hours. So somebody who is on 30 milligrams of or 60 milligrams of morphine, like our patient, would require practically 35 microgram per hour patch to help out. All right. So it's not a linear conversion. It doesn't work like that for buprenorphine. And there's also a sublingual buprenorphine which is available, and that is equal to 200 micrograms is equal to consuming like a dose of 8 to 16 milligrams of oral morphine. So the range is really wide. So with buprenorphine, I think the deal will be to go with a table, and if somebody is taking less than 30 milligrams of morphine per day orally, we can start with a 5 or 10 microgram per hour patch. It takes 3 days to start working for a 7-day patch, and then titrate slowly. Of course, you have to remember to give them rescue doses of morphine as calculated. So buprenorphine is not all that linear and straightforward, but it has its uses in patients with renal failure, in patients who are having addiction problems with chronic morphine use. It's a wonderful drug for that. But I am afraid that I don't have lots of experience with buprenorphine. I've used a lot of intravenous and neuraxial buprenorphine rather than transdermal buprenorphine. So yeah, that's all from me. I think we are done. Any questions? Any comments?
Ma'am, a patient on morphine comes to you with a severe acute pain. In that case, can we give buprenorphine for rescue pain?
The patient is on morphine. Why do you want to rescue with another analgesic which doesn't even have a linear conversion?
No, ma'am. Like the previous case, like vomiting, something like that.
Yes.
And the comes to casualty, you don't get the morphine without a prescription from some technical issues. In that case, if the resident from the casualty calls you, only this thing is available, can we give?
So you would, in which form are you going to give buprenorphine?
Injectables only.
Injectable form. If you haven't used it before, have you used IV buprenorphine?
No.
Yeah. It's a very potent drug. It has a good, ceiling dose for respiratory depression, but it's not that it doesn't cause respiratory depression. It can also cause respiratory depression. It can, it causes delayed respiratory depression. So one needs to be very aware of that. Are you trying to tell me that you can get IV buprenorphine without prescription?
No, ma'am. It's a hypothetical situation.
It's a hypothetical situation. So,
because ma'am, then my point was, if you combine morphine and buprenorphine, will it reduce the effect of morphine? Because it is a mixed agonist antagonist.
Yes, it will. I would like to combine both of them. I have I have seen it work. I have seen it not working so well when I combine morphine and buprenorphine. No, if I have a transdermal buprenorphine patch, my rescue will be sublingual buprenorphine. But let me tell you, sublingual buprenorphine in the first week causes a lot of vomiting.
Okay.
So I wouldn't like to combine. And having said that, when I put in a butrans or a bu patch for a patient, it takes 3 days to start working. So in an SOS situation, however hypothetical, it's not a realistic situation. You see, I can't rescue with that patch. It's just not going to help me.
Okay.
And of course, IV buprenorphine won't be available. So
Okay.
That's where it is. And yeah, Akhil has written that sublingual is used. Yes, sublingual is used. So again, the levels and all are a bit erratic there, but nevertheless, it will start working with under an hour. And definitely, yes, we don't like to combine opioids unnecessarily. So with fentanyl, yes, we do SOS morphine. That's there because there's no other alternative. We don't have another oral alternative. We don't have oral fentanyl, right? So there's no other choice there. But otherwise, we don't like to rescue with these things. Even methadone, of course, we do rescue with either sublingual buprenorphine and morphine sometimes. But these are particular situations where we combine two opiates. Otherwise, that's not the normal thing to do. Patient has vomiting, sometimes at home and all, when they don't have injectables, what we tell them is crush the powder, mix it with a little bit of honey so that the volume isn't much, and just coat it on the tongue. It will gently go inside without provoking too much of nausea or vomiting. That's what we tell people when they're at home, and before they can reach us, they still need to be the pain needs to be dealt with and the vomiting needs to be dealt with. So that's the immediate thing we could do. And we could also give them a mouth dispersible antiemetic in that situation. Yes, Dr. Ravi has written lozenges of fentanyl is available. Yes. Again, the conversion factors are not known for fentanyl lozenges. It releases something like 200 mics of fentanyl into the system. So if somebody is using this, they need to have naloxone available, and they need to be remembering that they should not give it to opioid naive patients. They need to remember that within 15 minutes, you must have removed the fentanyl lollipop from the mouth, and you should be able to take over the airway should you lose it, because 200 mics of fentanyl is a whacking dose.
Ma'am, I have a doubt.
Yes.
Regarding two questions. We have a patient, 88 years old male with CA lung cancer. The oncologist was reluctant to perform a biopsy, citing even if it turns after undergoing biopsy also, there's nothing much to offer. So without pathological diagnosis, can we prescribe the morphine on the triplicate prescription? It won't be any problem during the checking of drug controller or something like that.
Okay. Now tell me, was this Dr. Akhil speaking?
Ma'am, it's me, Dr. Ravi.
Oh, Dr. Ravi. Okay, yeah, your hand is up. Okay. So Dr. Ravi, yes. So you are saying CA lung. Now, how are you saying CA lung?
Ma'am, we have the PET-CT and the imaging modality.
You don't have the tissue diagnosis. You don't have a tissue diagnosis.
The oncologist does conclude that even if you have a tissue diagnosis, there's nothing much to offer for the 88 years old male, because is like the PPS is around 40 and the age factor 88. So they say even after getting whether it is squamous or non-squamous, the appropriate treatment in this age of patient and this profile will not get much benefit. So,
okay.
So can I start morphine because he has SOV of grade 2 MMRC and the skeletal meds and pain? Probably I have given for tramadol. I asked him to come back after 3 days to whether to check can I give morphine or not without a tissue diagnosis.
which we write in triplicate paper so that during inspection it won't be any problem, the drug inspector in such a case.
Okay, so I think the answer is yes, you can. If the patient has, either severe pain and breathlessness, or just breathlessness, and you think morphine is indicated, by all means, you will be. It is totally all right to give the patient morphine, and absolutely legal. Don't have to think twice about it, because here we are going around giving. We can give morphine in congestive heart failure. We can give morphine in COPD. So just because somebody has malignancy is not the criterion to give them a strong opioid. Yeah, if they have clinical indications, by all means, you are justified and perfectly above board in giving morphine. All right.
Okay, ma'am.
And I see another question here by Dr. Akhil. Liver compromise and renal compromise, safest opioids in these two situations. Can I just take that, Dr. Ravi, and I'll come back to you?
Yes, ma'am.
Liver
Yeah.
compromise, the safest opioid would be fentanyl, albeit you have to be a little careful in terms of applying a patch, removing the patch. Remember the latency, but fentanyl is the safest that we have. But you might need to go lower on the doses and maybe increased frequency if you are using intravenous fentanyl. As far as renal compromise goes, I think the mandate is very clear. We can use fentanyl, we can use methadone, and you can use transdermal buprenorphine or sublingual buprenorphine, because though buprenorphine is metabolized in the liver and has one active metabolite, which is not buprenorphine, it doesn't cross the blood-brain barrier. So though the clearance may be slightly delayed, it is not much of a problem. So these are the three opioids that we would use in renal compromise. But liver, sadly, we have only one. Definitely, we can't use methadone. Definitely, if your liver is not too badly off and your PT INR is not more than 1.5 times elevated, you could still use morphine, but at a lower dose at an increased frequency. Even sometimes OD, 5 mg OD, 5 mg BD, 5 mg TDS itself might be enough. Dr. Ravi, you were going to ask one more question.
Yes, ma'am.
I'm okay to log off anytime, Dr. Manu. I think the time is up. Anybody,
Yeah.
please feel
Yes, ma'am.
free to leave the meeting because the time is up. So
Ma'am, we'll go for this last question, and can we finish then?
yes, I think so. I hope everybody enjoyed this session. I don't know. I mean, this class would have been better in person rather than online, but it was fun interacting with everybody. Thank you for all your inputs and your questions. Yes, Dr. Ravi, let's not make it.
Ma'am, we have a patient of 48 years, female, CA breast, post-op, post-treated, and she has progressive disease, skeletal metastasis, sclerotic. She was she has diabetes, hypertension, CAD, CABG, and the cardiologist has advised avoid drugs causing QT prolongation. She was on
Okay.
buprenorphine 10 mics per hour. She has partially relieved suboptimal relief. Even tramadol, I have suggested 50 mg SOS. Two questions is which antiemetic is choice in this patient? And second, the analgesics morphine can be safely given in this patient.
Okay, so let me understand this question. So this QT prolongation is the problem here. And
Yes,
yes,
ma'am.
so QT prolongation, you don't want amitriptyline, you don't want haloperidol, you don't
Yes,
want
ma'am.
Perinom, you don't want olanzapine. I mean, these are
Yes,
the
ma'am.
drugs
Yeah.
when you say QT, this is what is coming
Yes,
to
ma'am.
my mind, quetiapine
Yeah.
and stuff like that. So these
Yes,
are the drugs which are bothersome. So yes, we won't go for that. Tramadol is, as far as I know, QT prolongation is not an issue with tramadol. I can check this again and get back to you. If I find something, I will definitely send it to Rajalakshmi and Dr. Manu. No, tramadol is definitely an option. But when you say she has got bone metastasis, And does she have brain metastasis? I mean, because then we
Ma'am,
can't be
no,
thinking of tramadol.
there is
Yeah.
no brain metastasis, ma'am.
Okay, so if it's only moderate,
Chest wall recurrence.
okay. So in that
Yes,
case,
ma'am. She
moderate.
has a chest heaviness, ma'am. She currently grade 1 is there as shortness of breath. She feels
Okay.
chest tightness more often.
So yeah, then I would go in favor of morphine. No, I mean, why would I be thinking of tramadol when she's clearly telling you one of the early signs of dyspnea and lung problems? I would go with morphine, and morphine, there's no QT prolongation paraphernalia. You can go ahead and give morphine. Your voice is breaking.
Antiemetic I should give.
You want to give an antiemetic, which is
which
not going.
antiemetic I can give along with morphine?
Okay, so I would we could just go with domperidone. Doesn't cross the blood-brain barrier. There's not much QT prolongation. Yes, there is high dose domperidone. There may be a problem. I'm sorry, I can't hear
Ma'am,
you.
which antiemetic of choice?
It would be domperidone.
MMG domperidone TID for 3 days. NMG domperidone TID. Yeah, TID.
Yes, absolutely. So what we have seen in our institution is most people don't even require 3 times a day. Even 10 mg BD is fine if you're so worried about the cardiac problems. 10 mg BD itself is fine. If she needs, you can give that other extra 10 mg as SOS. So that will be perfectly all right.
Fine,
so
ma'am.
morphine and domperidone would be just fine.
Fine. Thank you, ma'am. Thank you very much.
You're most welcome. It was a lovely session. Thank you, and sorry for making it late. Please.